Okay, so welcome back. We're going to talk about eating and hunger now, which was initially a part of the last lecture, but the PowerPoint started to get a little bit unruly, so I had to separate it into its own lecture, which is fine because realistically, there's a lot going on, and a lot of complexity with eating and hunger. So, why do we eat? I mean, this is pretty obvious for most people, right? Food equals calories, and calories is representative of energy. So cells need energy to function. Therefore, we consume food. We get all of our calories and our nutrients from the food that we consume. And there is quite a lot of physiology associated with this. So, the initial, one, as I kind of mentioned in the methods in behavioral neuroscience, like the way that we got to behavioral neuroscience was, through behaviorists, starting to care about physiology. So you had Skinner and people like him who were interested in behavior and learning, but then started to realize that methods in physiology would elucidate things about psychology that were important. And then you had people coming from the other way. So you had physiologists who were interested in consumption of food and water and things like this, and then realized that actually, in order to understand that, you have to understand behavior. So it's pretty complex. So we're going to go over some of the physiology here, not in great detail, but just so you can understand the gist, which is that, first, obviously, we consume the food. In our oral cavity, enzymes start breaking down the food, so enzymes that are produced by our saliva. Food travels down the esophagus to the stomach, and there's hydrochloric acid in the stomach and enzymes as well that end up breaking the food down even more. The stomach can store the food for a short period of time, which we will talk about momentarily, and ultimately causes stomach distension, which is one of the things that's going to cause satiety with us or for us. But eventually, food empties into the small intestines. The small intestines have more enzymes to further break down what was not already broken down by the oral cavity or the stomach. And then the small intestine starts to absorb nutrients and traffic it into the blood. So, I think that this is something that is sometimes a little bit overlooked, which is that like the nutrients and the calories in the food need to ultimately get to the blood. So some people have disorders where they don't have a functioning stomach, or they don't have the capacity to eat solid foods or even liquid foods. So they will actually get infusions directly into their heart or their bloodstream, their vasculature, with the requisite nutrients, and be able to survive that way. What's left travels into the large intestine, which is essentially the colon, where water and minerals are reabsorbed, and then whatever is left of the food obviously is going to be excreted as feces. So that is the husk of the food that's left in the rectum, which eventually is going to be expelled. Milk and early life feeding is kind of interesting. Most mammals survive on their mother's milk initially for days or years, depending on the species. But almost all mammals, except for humans, stop consuming milk. And that's due to a lack of availability of milk or sustainability of it as a food. And also the subsequent reduction in lactase. So lactose, which is a sugar in milk, is initially broken down by high levels of lactase into glucose and galactose. But most adults, depending on their culture, actually don't have enough lactase to break down lactose, which then causes stomach irritability. So it kind of depends on the region and the area of the world that we're talking about. Obviously, in the United States, we consume a lot of dairy products that contain lactose, like cheese and milks and ice creams and things like this. But depending on where you are in the world, for instance, in China, there is almost universally in China, people don't have enough lactase to break down milk, which causes stomach issues. So, and also in surrounding countries to China. Obviously, you can fix this by taking external lactase or exogenous lactase. to help you break down the lactose. But the reason why some individuals can break it down and some can't, well, not individuals, but why there are regional differences seems to have to do with cattle rearing and the use of digesting lactose historically. So there are both short-term and long-term regulation mechanisms of feeding, because initially, remember, this was a homeostasis lecture. So obviously we have both homeostatic and allostatic mechanisms to avoid over or under consuming food. Having sufficient calories is vital, obviously, and a lack of calories results in starvation, but also cellular mechanisms breaking down. So if you all remember the sodium potassium pump from our action potential lectures, that is excreting sodium and bringing in potassium, and that helps maintain the resting membrane potential at a particular threshold. When you have a reduce or a lack of calories, or if you're starving, then the sodium potassium pump doesn't have enough energy to work at the rate that it should be working, which ultimately increases the resting membrane potential because it's not expelling all that excess sodium. So since the resting membrane potential is increasing, that means that the threshold in order to have an action potential is easier to reach. Ultimately, what this results in is, action potentials occurring when they shouldn't, which ultimately is going to cause dysfunction. So in order to save the sodium potassium pump in the long run, it works less, which ultimately increases the resting membrane potential, which ultimately results in more action potentials in an inappropriate setting, which causes cellular dysfunction. And then, of course, once you reach a point of having not enough calories for any cells to function, then that is what starving to death is caused by, right? So eventually you won't have enough energy for anything to function. There are a lot of factors that inform our body about the calories that we're consuming, and oral factors are very important. So you can survive without using your mouth. You can survive without even using your stomach, really. Like I said already, you can get cardiac infusions directly into the vasculature of nutrients to keep you alive. Or in this example, where there's a tube bypassing the oral cavity going directly to the stomach, you can definitely survive this way. Or some people also have a, I can't remember what it's called, but they basically have an opening in their stomach where they will inject the food directly into the stomach. So obviously you don't need the mouth to survive or to give all the feedback about what you're eating to the brain, but bypassing the oral cavity is less satiating. So the oral cavity does have some role in satiety. So you'll need to know that the oral cavity does have a role in satiety, but obviously it's not enough because you won't just get full by putting food in your mouth and spitting it out. So this was first discovered a long time ago in studies that would use gastric fistulas. So this was a technique where they would put a hole in the stomach of an animal. Routinely it would be dogs, but they also did this with horses, where they would put a gastric fistula in the horse and test drinking behavior. So how much would the horse drink? This is a representation of a dog, but basically the dog was allowed to eat, and either there'd be a fistula, in this scenario it's showing a fistula in the stomach, but you could have fistulas in various places to test when or where satiety was being signaled. But basically here, the dogs would just continuously eat, because when this gastric fistula was open, the food would go down, past the oral cavity, down the esophagus and into the stomach, but then it would fall out of the stomach. So since it couldn't actually stay in the stomach, the animal would never get indication that it's consumed enough calories. So oral factors do play a role in satiety because people find it less satiating if they bypass the oral cavity, but the oral cavity doesn't produce all of satiety. In fact, one of the main factors that produces satiety is gut distension. So stomach distension is the main signal to end a meal, and this is happening when we are filling up our stomach with food, and this little sphincter from the stomach to the intestines is closed, not allowing the bypass of food, which ultimately causes the distension. This is also how, since this is the main signal to the brain that we've consumed enough calories, this also kind of explains how we know to stop eating before we've actually got the energy in the cell, right? Because the whole point of eating and getting the calories is to increase the energy that we have in our body, right? But when it's in your stomach, you don't yet have the energy. So similar to like what we were talking about in the homeostasis lectures, a lot of the physiological feedback mechanisms that are causing a behavioral output or inhibiting a behavioral output are essentially stopping before the body has actually gotten the thing that it was seeking, right? So in this case, it's calories. In the thirst example, it was, sufficient hydration or electrolyte balance. But anyway, the main signal to stop a meal or that you have had sufficient calories is stomach distension. So the stomach is connected to the brain through the vagus nerve, and ultimately the gut has these nerves, primarily the vagus nerve, that is going to communicate with the central nervous system through a variety of basically different pathways. But ultimately what's happening is that the vagus nerve is communicating information from the gut to the hypothalamus. And the hypothalamus is then saying, okay, we need to release some information to the rest of the body, the peripheral and central nervous system, to stop the consumption of food. So you'll definitely need to know that the main inhibitory mechanism to signal the end of a meal comes from stomach distension, and that this information is being sent to the central nervous system through the vagus nerve and ultimately to the hypothalamus to inhibit food consumption. So the stomach and intestines also play a vital role in this. The duodenum or the duodenum, both of them are correct, absorbs nutrients and sends this information to the brain, and then satiety hormones are released locally. So you actually do have some satiety hormones that are released from the gut itself, and one of those is cholecystokinin. So CCK is a major satiety hormone that creates satiety through two specific mechanisms. The first one is that it constricts the sphincter muscles between the stomach and the duodenum, causing the stomach to hold its contents and fill more quickly, which results in distension. So like I said, the food gets put into the gut. The gut is sending signals to the brain, but also locally releasing cholecystokinin, which then inhibits gut motility and flow of the food into the intestines, which ultimately causes more distension. So that's the first mechanism, is that CCK is causing distension. The distension is signaling to the brain that you can stop eating. It also stimulates the vagus nerve that sends a signal to the hypothalamus to release satiety neurotransmitters in the brain itself. Unfortunately, cholecystokinin or CCK is not a good treatment for obesity because it only produces short-term effects. So animals treated with cholecystokinin have a decrease in the immediate meal size, but they have a rebound effect where they consume more food in later meals. And this indicates that there is another system that tracks the overall weight set point. So this is something that's very important for the obesity discussion. Obesity is a chronic health condition that the United States and realistically many Western countries are dealing with. It is often one of those disease states that, like drug addiction or some other disorders, is kind of looked at as not really a disease. It's looked at like people are having an issue with willpower. Let me just make sure that I don't have an obesity slide. I mean, I know that I have obesity slides later, but I want to give the obesity public service announcement now. But basically, there's this idea that people that are obese or severely overweight are just weak and have no willpower, But when you're looking at the trends of obesity over time, it's pretty staggering to witness what's happening to. I'm not sure about other Western civilizations. I know that they're dealing with a similar thing, but if you look at a map of obesity in the United States over time, starting with the 1950s until contemporary America, the rate of obesity is staggering. And what that is correlated with is highly calorically dense, low nutrient foods. You know what I mean? Like, or not low nutrient because they have a lot of calories, but I just mean that they don't have anything else in them. It's just empty calories, highly processed, extremely calorically dense, very highly palatable foods that kind of trick you into never feeling satiated, but nonetheless have all those calories, which results in an increase in adiposity, which is fat tissue. And then also you have this situation, which is that your body, once it's used to a particular weight, it will defend that weight. So your body is not aware that being, 5'5" and 240 pounds is a problem. If you are 5'5", 240 for long enough, your brain will now calibrate this to be a normal weight for you, and it will defend that weight. And this is a very important example here, which is that you have certain mechanisms that are going to temporarily change your feeding patterns. But there's an overall regulation system that is keeping track of where your body weight is supposed to be or where it thinks it's supposed to be, which will then cause you to be hungry later on. So this is why crash diets are really ineffective, or when people are essentially not anorexic but will starve themselves for periods of time. Maybe they'll go throughout the week, many days of having a very strict diet. Maybe they're eating only 1,000 calories per day, but then they have a binge on the weekend where they eat 5x what they've been eating on a daily basis. And ultimately, the way that your body is maintaining its weight or its level of adiposity or its muscle content is through long-term caloric consumption. So on a weekly basis, if you're eating 20,000 calories to maintain your weight, it doesn't matter if you only ate 5,000 calories Monday through Friday, but then ate 15,000 calories on Saturday and Sunday. You know what I'm saying? So it's like if ultimately what's going to determine your body's weight composition and ultimate body fat percentage or musculature, or the amount of muscle that's on your body, is going to depend on total caloric income and output. So again, like if your body is telling you that you need to maintain 20,000 calories a week, it is really very challenging to force your body to and force yourself to ignore the cues that your body is sending you. When somebody is overweight, it's because they are hungrier. This is, now there's also psychological, pathological outcomes that may be contributing to emotionally eating and things like this. But ultimately, once you've got your body to a certain level of, a weight for long enough, your body's going to defend that. So, and like we kind of had examples in the homeostasis lecture with trying to stay in a sauna long enough, or past the point where you want to, or once you're thirsty, trying to not drink. I mean, eventually what ends up happening is that your drive states to either increase calories, get out of the hot sauna, or consume fluid is going to overwhelm your cognitive control over your behavior. And the reason why that is because the part of your brain that's controlling your executive decision making, which is your cortex, it will become underactive essentially. And these other systems that are in your limbic system or in your hindbrain that are driving these behaviors will become overactive to defend the state. Now, that doesn't mean that you shouldn't try to lose weight, and that's why having weight loss interventions like GLP-1 drugs and bariatric surgery are imperative. is because they can actually take away some of the physiological pressure that people are under with this. So I just want to kind of have this PSA, which is that obesity is absolutely a disease state. And even if it wasn't, and even if it was an issue where people just had a lack of willpower, what's the alternative? We just want like 80% of our population to die? You know what I mean? Like, that's not helpful for anyone. You know what I mean? So I think that it's really important that we normalize these obesity treatment drugs in an appropriate way. Obviously, if you're not obese, then you should not be taking Ozempic, in my opinion. But, you know, if you need to lose 10 pounds, that's not going to require bariatric surgery or pharmacological intervention. But be that as it may, this is a good example of how our homeostatic set points are driving our behavioral outputs, because even taking exogenous hormones like cholecystokinin does not ultimately treat the obesity issue, because you have more powerful hormonal regulators, which will then force you, or, you know, produce a physiological milieu or environment that is going to drive you to consume more calories if you were deficient in one particular meal. So that was a whole long rant, PSA, whatever you want to say. The part that you need to know about cholecystokinin is that it's causing its effects locally at the duodenum by constricting the sphincter and not allowing stomach emptying into the intestines. It also stimulates the vagus nerve that sends signals to the hypothalamus to release neurotransmitters in the brain that are going to produce satiety. You also need to know that there is another system that will overpower CCK, which tracks our overall weight set point. Okay, sorry about that. So we also have glucose, insulin, and glucagon. So glucose, I think most people are going to be familiar with glucose. It's a simple sugar, and it's the main source of energy for our brain and our body in general. And this is going to cause another rant that I'm going to try to not go too crazy on with carnivore diets, but we'll get to that. So we also have insulin, which is a pancreatic hormone that, when released, traffics glucose into cells. And then we have glucagon, which is another pancreatic hormone that increases glucose in the blood through gluconeogenesis. This is production of glucose from non-carbohydrate substrates. So the rant about the carnivores, I'm not going to get too crazy on this, but you know, the idea that glucose is bad for you, or the idea that sugar is not good in some way, is totally like BS, because when you are, like, glucose is the easiest form of energy for your body to use. So when you're starving your body of glucose, then the body will actually release glucagon and produce gluconeogenesis, okay, because it needs glucose to survive. So obviously you can survive off of ketones and other sources of energy, and your body will do that, but it's not ideal. The easiest thing for your body to do is to use glucose as an energy source. And even if you're eating no glucose, your body will eventually produce glucose from stored glucagon. So you need to know what glucose is, you need to know what insulin is, you need to know that glucagon will produce glucose through gluconeogenesis. So these sugars and hormones are incredibly important for appetite and energy homeostasis. So when you have cues like a smell, or even, you know, like maybe you hate McDonald's, so maybe this is like making you want to vomit, but I love McDonald's fries and the McDonald's sodas, so it makes me kind of hungry. But this is a learning property, associative learning, that essentially ties these cues with those hunger hormones and those states. So even these, the smell of McDonald's or looking at this can release insulin. And insulin is very important because it is how we get glucose into our cells. So you have an insulin receptor and you have a glucose channel. And when you're eating and your blood glucose is increasing, you start to stimulate insulin release. Insulin binds to the glucose or the insulin receptor, which then ultimately opens up this glucose channel, allowing glucose to enter the cell, and then the cell will use that glucose as an energy source. So it's just really important to note that insulin is how your cells can get energy. Without insulin, the cells are going to starve to death, essentially. Now, the exception to this is with neurons. Glucose is incredibly important for neuronal activity and for the energy that neurons use. So glucose actually can just fully penetrate nerves or neurons. So the liver stores glucose as glycogen. So if you have unused glucose that doesn't need to be used right away, it will be stored as fat, or it will be converted into glycogen and stored in the liver. So you'll need to know that. Okay, so the whole point about homeostasis is that we have particular need states that homeostasis is going to try to get us back to, right? So homeostasis is the mechanism by which our body is maintaining set points, and the set points are derived from certain need states. And need states could be because we need glucose for energy, or it could be to avoid excess glucose, which can be harmful. So if we have glucose in the system, we have the release of insulin, and then insulin reduces our blood glucose. Okay, so that's very important to know. Too much glucose in the blood will cause damage. Let's see, do I have what this is called? So insulin's ultimate job is to keep blood glucose at a reasonable level. So we're going to talk about that in a minute, but I just want to point out that just like with having too much water and the electrolytic imbalance that can happen through hydrotoxicity, or not having enough water and having too much electrolytes will cause our neurons to not even be able to function. This is essentially what's happening all the time with the various things that we need in the body. We need glucose, we need electrolytes, but too much of these things can cause irreparable damage. I know that my head is covering this, but it says to keep blood glucose at a reasonable level. So hopefully you're following along with your own PowerPoint. So dropping insulin levels will ultimately stimulate hunger. So as time passes after a meal, insulin levels drop, and this results in a decrease in glucose entering the cells. And this starts to produce a feedback loop that will ultimately result in hunger. So what also happens is that after time passes from the meal, we have a release of glucagon from the liver, which ultimately is going to produce glucose through gluconeogenesis. So let's go ahead and talk about diabetes. There's two types. There's type 1 and type 2 diabetes, but there's also two disorders that are called diabetes. One of them is diabetes mellitus, which is what we're going to talk about, and the other one is diabetes insipidus. Diabetes insipidus, actually, I probably should have gone over in the last lecture, but I just felt like it was a little bit too convoluted, so I didn't go over it. But I'm just briefly going to tell you that diabetes insipidus actually has nothing to do with insulin levels and actually has to do with vasopressin deficiencies. Vasopressin is an anti-diuretic hormone. It's what allows you to pee or to not pee. And so people that have diabetes insipidus essentially have a dysregulation of thirst because they're always peeing. They're unable to hold onto their body water, which ultimately makes them thirsty constantly. So diabetes insipidus can be dangerous, but ultimately it's kind of a quality of life thing where it's just really annoying and uncomfortable to be thirsty all the time and to be peeing all the time. And diabetes insipidus, I'm not going to ask you about this, but just in case anyone's interested, diabetes insipidus is caused through either being deficient in vasopressin, which is central deficiency in the brain, or by having some kind of problem with vasopressin receptors. So you have plenty of vasopressin in the system, but it doesn't work properly with the receptors, which ultimately causes you to pee constantly and therefore drink constantly. But that's diabetes insipidus, has nothing to do with what people normally think of as diabetes, which is diabetes mellitus. This is characterized by sustained high levels of blood sugar, and there is type 1 and type 2 diabetes for sure. I'll ask you about the different types, so you'll need to know about this on the exam. But type 1 diabetes begins often early in life, and normally it's because of an autoimmune attack that reduces or eliminates the ability of the pancreas to produce insulin. So insulin is a pancreatic hormone, which means it comes from the pancreas. And the damage that happens in this scenario results in insufficient insulin. This requires the patient to give themselves exogenous insulin and follow a very strict diet. And remember, the whole point of insulin here is to reduce overall blood glucose. So, and also traffic glucose into the cell. So it's doing two things. It's what is giving your cells the ability to use glucose as energy, and also it is removing excess glucose from the bloodstream, which ultimately will cause toxicity if you have too much glucose. So we also have type 2 diabetes, which normally begins in middle age or later, but obviously has been happening in children today due to our increased calorically dense, hyper-processed, hyper-palatable foods. But anyway, it occurs in association with obesity and the lack of exercise. And in this scenario, the pancreas produces enough insulin, but the cells have become unresponsive to it. And that's because of tolerance, basically, to insulin floating around in the blood. So if you remember from our psychopharmacology lecture, we talked about sensitization and tolerance. And in this scenario, basically, since there's always insulin floating around, the cells become tolerant to it. And insulin is always floating around because of the overconsumption of energy, which is producing, primarily glucose in the blood. So, and by energy, I mean calories, right? So that's why people with obesity tend to have diabetes. Now, it doesn't always have to be people with obesity. It can be people who also have a lack of skeletal muscle. So sometimes people who are very thin will get type 2 diabetes, and people are sometimes confused by this, but it's because of the same scenario. Due to a lack of muscle, they still have a high body fat percentage and are still overeating for their body weight, which ultimately results in an increase in blood glucose. So basically, since they don't have the metabolism that's necessary to utilize the sugar that they are consuming, they still develop type 2 diabetes. So a problem in both obese and non-obese individuals. It's not so much a problem in individuals that are highly active. This is a problem of inactivity. So even if you're, not obese, but you're not exercising, that is a huge problem. So exercise. Anyways, both types of diabetes will result in the inability of glucose to enter the cells, which has two major harmful outcomes. One is glucotoxicity, which is what we already talked about, which is that sustained high levels of glucose causes physical damage. This can be a variety of things, which is like your blood doesn't clot properly, which results, or your wounds don't clot. The blood from an open wound doesn't clot properly, which ultimately can result in infections, and also a lack of nociception in the feet. So you don't actually even realize, a lot of times people that have severe diabetes will have amputations starting with their toes and then their feet and then their legs, because essentially what's happening is that they're getting cut. They don't feel that they have a cut. The cut is not healing and it becomes infected. That infection then needs to be removed, and a lot of times people are not aware of the infection until they get to the point where it's so bad that they need amputation. And this will happen where people are literally, will lose a leg eventually. It's terrible. You also have blindness can be caused, can be an outcome of glucotoxicity. So Yeah, it's a total nightmare to have diabetes, and to have glucotoxicity. There's a lot of negative outcomes. The one that's like really kind of disturbing is starvation. So if insulin is either not present or if the cells are resistant to insulin, this means that glucose can't be trafficked into the cell, um, which means that the cell doesn't have energy, which means that the cell is going to die. And ultimately, the patient will die of starvation. So this is why you have a paradoxical relationship with weight loss and diabetes. Some people with undiagnosed diabetes will have rapid weight loss. And this is because of the fact that the cells are not utilizing the exogenous, like the energy that that person is consuming, because the cells have become tolerant to the insulin. So essentially, you have somebody who has undiagnosed diabetes rapidly losing weight, and this is not a good thing. This means that essentially what's happening is that the individual is trying to use their fat as energy, because that's where the energy is stored, is in the fat, even though they're probably consuming enough calories. They can't use those calories, resulting in fat storages being used and ultimately them dying from starvation. So this obviously doesn't happen. Most people that have controlled diabetes may still have obesity, and many people with diabetes don't just all of a sudden lose a bunch of weight, but there is a percentage of the population that will have rapid weight loss because they were totally unaware of the fact that they were diabetics. So diabetes is a real unfortunate condition, and another example of why obesity needs to be taken very seriously and is not something where you should ignore it if you are obese. It should be treated because it is a very serious condition that will result in several life-ending disease states like hypertension, which ultimately leads to cardiovascular disease and heart failure, and diabetes, which will ultimately result in the inability to use your energy properly that you're consuming. And on the flip side, it needs to be taken seriously because it is a disease state that, although it seems like it has a behavioral treatment, the behavioral treatments themselves are oftentimes not effective. So, why it's not effective, whether it's patient adherence to the protocol, or if it's because, that's honestly why it's not effective, generally speaking, is because patient adherence is not really possible. And I just want to harp on this a little bit more just because of what a big deal it is in our society. Patient adherence to treatment is part of the efficaciousness of the treatment. If you have a treatment methodology that causes your patient to be so violently nauseous that they don't want to take the drug, then that's a bad drug. Similarly, if you have a treatment methodology where patients cannot adhere to the schedule, such is the case oftentimes with diet and exercise, then it's not a very good treatment unless you want to be cold-blooded and just say, well, I guess you're going to die. As a society, we can then, think of other ways to help people lose weight, and GLP-1 agonists. I don't work for GLP. I don't care, do what you want. I just know that my family has been affected a lot by obesity, and as a personal trainer that I was for many years, I saw people struggling with weight loss. These people are trying really hard, but it's really hard to fight your biology. So in any case, it's very serious. Diabetes, very serious. Obesity, very serious. But luckily, we do have some very good treatments for obesity these days in those GLP-1 drugs. Moving on to leptin, another satiety hormone. The question remains, as we talked about with cholecystokinin, that there are both short-term and long-term mechanisms that mediate your caloric consumption, or kind of look at your overall set point in weight. So short-term satiety is produced by cholecystokinin, CCK, and interoceptive cues. But how do interoceptive, meaning like when you feel full? Interoceptive is talking about like the internal states. that you're experiencing. But how do we maintain our weight set point long term? And one of those methods or mechanisms rather is from fat tissue. So the more fat tissue you have, the more leptin will be released. Leptin is a satiety hormone released by adipocytes, which are fat tissue cells, and they signal to your brain about how much fat reserves you have. If you have a decrease in fat, this will decrease leptin, which increases your hunger and decreases your activity. So less leptin will result in an increase in food intake and a decrease in energy expenditure. When you return to normal, you will have less hunger and more activity. So like we said already, fat tissue is producing leptin. And so if you have more fat tissue, you will have more leptin. This can be a problem as high leptin can trigger puberty. Lower weight individuals tend to start puberty later than those who are heavier, and this kind of makes evolutionary sense, since if you are starving, then you don't want to procreate or put energy towards being able to procreate. You need to save that energy for your own survival. And leptin is really interesting because initially, when it was discovered, which was many decades ago at this point, it was thought that leptin was going to be used as a major weight loss solution. But we'll get to that momentarily. But there are genetic deficiencies that can make an organism not produce leptin at all. So this is a knockout mouse that has no leptin. And as we can see, this little guy is a very chubby guy. And then we have a leptin deficient mouse that's getting exogenous leptin, and they return to normal. This is also something that happens in humans. So some humans have a genetic deficiency in leptin, and for those individuals, exogenous leptin supplementation can cure their obesity. So this is another example of why certain behavioral disorders are very deceptive. Because just look at this right here. I mean, this individual is clearly obese, and you could be blaming the parents for this, you could be blaming society for this, you could be saying it's the sugary foods, and no doubt it has to do with the high caloric, highly palatable foods that we have in our society, because if this person had no access to calories, then obviously they would not be able to get to this weight. But it's the combination of the genetic predisposition with the environmental factors, right? So that's true of all disease states, and you should learn, if you take a, I can't remember what it's called, but the, psychopathology course or whatever, like all psychological disorders and all disorders and disease states in general are a mixture of environmental pressure and genetic predisposition. So you have this individual who literally doesn't produce leptin and gains weight because they have no signal to their brain indicating that they are a sufficient weight, so they're constantly hungry, constantly having a drive to consume and consume to a point of obesity. But then with supplementation, they go to a normal weight. So it's pretty... it's a pretty staggering treatment outcome. Now, the problem is that most individuals who are obese do not have a leptin deficiency. So most people who do not have most people do not have a leptin genetic disorder and have plenty of leptin in their system. And leptin has modest effects on hunger. So if you have it at all, you're already getting the benefit from it, and adding more leptin does not decrease hunger. And this goes to show the evolutionary prioritization of hunger and avoiding starvation compared to combating an environment with a caloric surplus. So essentially what I'm saying here is that they initially found leptin, pharmaceutical companies went after this, tried to use that as an obesity drug, but once it got to trials with individuals who already have leptin, it was found that it really didn't help anybody past that point. So if you have a leptin deficiency or you have insufficient leptin due to a genetic predisposition, then that will cause severe obesity that can be treated. However, most people are basically have plenty of leptin floating around constantly, but it has diminishing returns. So if you have leptin at all, essentially that's going to produce the inhibitory feedback loop as much as it will. You know what I mean? So it's like you can't go above and beyond just turning on this satiety mechanism. Once you start taking more leptin, it's insufficient. And basically what this last little bullet point is showing is that, another issue is that evolutionarily, we've never been in a situation before where we had so many calories at our disposal. All organisms are always, scrapping, clawing and scratching to stay alive to get enough food to eat. And most of the time we were starving. So when you have enough food around, then the biological predisposition is to consume and consume. And that is kind of reiterated by the fact that, although we do have the satiety hormone in leptin, adding more of it doesn't actually help anything. So we'll talk about some neurotransmitters and brain areas that are important for weight loss now and weight maintenance. And the hypothalamus is important for regulating feeding behavior. I've already kind of mentioned this in the homeostasis lecture, that it was important for temperature regulation. It's also important for feeding, and it affects hormonal responses released into the bloodstream, adjusts the balance of sympathetic and parasympathetic nerves, the parasympathetic nervous system, and it initiates somatic motor behavioral responses. So the hypothalamus is keeping track of all the things that we need, essentially. I mean, like, basically whenever there's a question about homeostasis, it's a pretty safe bet that the hypothalamus and the pituitary are going to have something to do with it. So we know this, obviously, primarily from animal studies, that if you lesion a specific area within the hypothalamus, it can cause anorexia or it can cause obesity. So we have lesions in the lateral hypothalamus, which will cause starvation, and then lesions in the ventral medial hypothalamus will cause obesity. So if you remember from our neuroanatomy lecture, lateral means towards the sides. So we have the hypothalamus in general is this area right here underneath the thalamus, and the lateral hypothalamus is this area that's being pointed to here. The ventral medial hypothalamus is just saying the ventral and middle, or towards the midline, and ventral meaning towards the belly area of the hypothalamus. So if they destroyed the lateral hypothalamus, the rats would starve, which means that the lateral hypothalamus is driving consumption, right? If you destroy an area of the brain and it causes starvation, then that means that that area of the brain must be driving food consumption or caloric consumption. In the other scenario, the ventral medial hypothalamus is causing satiety. So if you destroy that area of the brain, you get obesity, right? That makes sense. So let's go ahead and look at this graph and go through it. So we have a normal rat body weight, and we can see that when it's food deprived, it dips in its body weight, and then we can see that it goes back to normal. And then you can see here that the lateral hypothalamic lesioned rat has an overall lower body weight than both the normal rat and the ventral medial hypothalamic rat. So what this is indicating is that the animal is eating far less than it otherwise would. And then we can see a ventral medial hypothalamus lesioned rat where the body weight is very high. So what this means is that, again, the ventral medial hypothalamus is important for satiety, and that the lateral hypothalamus is important for hunger signals. So I know that can be a little counterintuitive because destroying the lateral hypothalamus resulted in starvation. So that might make you think, okay, the lateral hypothalamus is important to inhibit food intake, but it's exactly the opposite. So if that doesn't make sense, kind of try to run through that logic a couple times. So it will start to make sense to you. Okay, so moving on to the arcuate nucleus. This is a very important area of the brain. It's an arc-shaped hypothalamic nucleus with a network that integrates hormone that integrates hormone signals from the body. So this is an area of the hypothalamus, the arcuate nucleus, and it is integrating information from the nucleus of the solitary tract, or called the NTS. So you have afferents from your GI tract, which again, afferents means arriving signals, that is talking to the NTS. The NTS is then also going to send information to the arcuate nucleus of the hypothalamus, which is going to communicate with various areas of the hypothalamus, like the lateral hypothalamus or the paraventricular nucleus, through these satiety hormones and neurotransmitters. So for instance, we have POMC neurons, which are satiety hormones, which are going to inhibit the lateral hypothalamus. So if you remember from this slide that we just went over, we said that the lateral hypothalamus is going to largely stimulate eating. And that's true, but POMC neurons are inhibitory. So if we inhibit this lateral hypothalamus, then we're going to have a decrease in food consumption. So we're going to go over, you're going to need to know essentially the bullet points about these neurotransmitters. But in the arcuate nucleus, we have NPY neurons, which act as hunger neurons, stimulating appetite and reducing metabolism when activated. They produce neuropeptide Y and agouti-related peptide, which is AGRP. So if we have NPY, which is here, that is going to stimulate food intake. So we have NPY neurons here, and they are going to increase food intake. We also have AGRP neurons, which are not on this picture, but also are going to increase food intake. We also have POMC neurons, which are satiety neurons. So when activated, they inhibit appetite and increase metabolism. And they also produce opiomelanocortin and cocaine and amphetamine regulated transcripts. So one of the effects of stimulants like cocaine and methamphetamine, nicotine, and a variety of stimulant drugs is a reduction in appetite. And this is actually not simply that you're forgetting about the fact that you need to eat or something. It actually causes satiety with CART, which is this cocaine and amphetamine regulated transcript. So I'll ask about CART. I'll ask basically how do POMC neurons produce satiety, and one of those mechanisms is through CART, which is cocaine and amphetamine regulated transcript. We also have ghrelin, which is a hormone released by the stomach, and this is a hunger hormone. So I always remember that because ghrelin sounds like growl, and when I'm hungry, my stomach is growling. So hopefully that's helpful in some way. But it stimulates NPY hunger neurons, and these levels increase during fasting and stimulate appetite. So ghrelin is another hunger hormone. And then we have PYY3-36, which is a peptide released by intestinal cells, which inhibit NPY hunger neurons to reduce appetite. And these levels increase during ingestion. So you can see that there's a lot of neurotransmitters and hormones and peptides that are being released that modulate or change your subjective feeling of hunger. So be familiar with these. I haven't developed the test questions yet, but I will ask about all of these hormones that I have highlighted here. So you should know about neuropeptide Y. You should know that that is a hunger hormone. You should know that POMC neurons are satiety hormones. I'll ask about cocaine and amphetamine and regulated transcript, in that they are produced by stimulant drugs, but also in general, it is a endogenous mechanism of satiety. You should know that ghrelin is a hunger hormone that's released by the stomach, and that it stimulates NPY neurons, which are hunger neurons. And then you should know that PYY3-36 is a peptide released by intestinal cells, and that they inhibit NPY hunger neurons to reduce appetite. So you can see how these different neurohormones and neurotransmitters are working in conjunction with each other, which is that we have one that's stimulating NPY neurons and one that's inhibiting NPY neurons. So, and that the NPY neurons and the POMC neurons are the two primary hunger and satiety neurons within the hypothalamus. And again, that's because they're in the arcuate nucleus, which is in the hypothalamus, right? So, okay, so got a little bit dense there at the end, but basically, I think that we've hit everything that we need to hit for hunger, and you can now see why this was separated into its own lecture. But I think that this actually ends Module 3. So, yeah, this is the last lecture in Module 3, which leaves only Module 4 left, I believe. So, and that will be the shortest module of only 3 lectures, but they are a little bit dense. So, hope you enjoyed this. I hope everyone's doing well, and I will see you in the next video.